Hello. Um, Nice to see you all. Thanks so much for joining us. My name's Martha, and I am a director and co-founder of Foxglove. So sorry that we're starting slightly delayed. Thank you for bearing with us. And we're so pleased to see you joining us at this supporter event about the future of our NHS health data. I think you all know Foxglove quite well at this point. Many of you indeed are friends of Foxglove and have been involved in our work to ensure that NHS health data remains a public asset used for public good for some time. Indeed, many of you have supported our campaigns and litigation and contacted MPs and much more, so thank you for joining us. But in case you aren't familiar with Foxglove, we're a non-profit and we exist to make the use of technology fair, and we litigate and we campaign. And today I am absolutely thrilled to be joined by my co-founder Corey, who many of you already know as well, and two doctors and campaigners, Dr Marcus Baw and Dr David Nichol. So thank you so much for joining us and welcome to them as well. Before we get started, it would be great if we could just do a quick round of introductions, not from everybody, sadly, that would take us some time, but from Corey, Marcus and David. If you could briefly introduce yourselves, that would be wonderful. Corey, we'll come to you first, if that's okay.
Good evening, everyone. Thank you so much for being with us today. I am Corey, and with Martha, I'm one of the founders and directors of Foxglove, and we are supporting a group of people, including the National Pensioners Convention, Just Treatment, and the Doctors Association UK, to potentially challenge the new plans for the federated data platform. And we'll talk more about it.
Thanks so much. And next over to you, David, if that's okay.
That's fine. Thank you for the intro. I'm really sorry the video is not working. Isn't it embarrassing to have a talk on technology and the technology doesn't work? I'm clinical lead for neurology in Birmingham, but I'm here on behalf of the Doctors Association UK, who were involved in the initial case, and we could talk about how trust is vital in terms of the doctor-patient relationship.
Great, thank you. And Marcus?
Hi, everyone. I'm Marcus Baw. I'm a GP in Yorkshire. I'm involved in GP technology, GPIT, and through that have become involved in various data platforms that the NHS has spawned over the years, and become fluent in the whys and wherefores of these things and the risks associated with them.
Great, thank you. So just to give a brief outline of what we'll do in the next just under an hour, we're hoping this will be more of a conversation than a sort of panel discussion, and some of you indeed have already submitted comments or questions in advance, so thanks so much for that. But we'll spend the first kind of 30 to 40 minutes in a conversation between the panelists, and then we invite all of you to ask questions. And please do feel free to submit those in the chat at any point throughout the session. Indeed, the earlier the better. And please also indicate if you'd like to turn your video and your sound on and ask the question yourself, or if you'd like me to ask the question. Either is absolutely fine. And so without further ado, I think we'll get started. So Corey, if it's okay with you, we'll come to you first. It would be great if you could give a bit of background, and you mentioned this a bit earlier, but if you could give a bit of background on Foxglove's work on NHS health data, what Foxglove's done over the past 3 or so years with our partners, and why that's so important to our work.
Sure. It's a tale of multiple started legal actions, but the basic principle, I think, behind what Foxglove is hoping to do, partnering with groups like the National Pensioners Convention, with Doctors Association, with Just Treatment, is basically ensure that patients have a say over who sees their health record and on what circumstances. And ever since COVID in particular, it feels that there has been a push from within government again and again in different ways to centralize health data and to centralize control over health data while skipping really crucial questions and steps about garnering patient consent. And we have a lot of concerns about that. So we're going to talk about Palantir, but I just wanted to begin by saying that for us at Foxglove, as an organization that wants to make the use of tech fair, we're not opposed to the NHS making better use of its data for your direct care or to be more efficient. What we are very concerned about is the idea of data being pooled into a centralized database and then being made available to lots of other people with different use cases. So your care is obviously very different from something like planning or commissioning. That itself is very different from the idea of research, especially for-profit research. And there's been a really regrettable tendency, I think, on the part of government to lump all of those incredibly different purposes together into one policy statement, which is basically just data saves lives, and the hopes that they can kind of get any policy through under the same umbrella. Data can save lives, but can also make a lot of people quite a lot of money. And actually, people should have a choice, we think, when it comes to their personal patient record. And you've got two doctors here to talk about trust. I won't talk over them. But a choice about those sensitive health records and who sees them and under what purposes. So in terms of what Foxglove's been doing, I know we have a little bit of not too much time, so I won't go through all the ins and outs of all the cases that we brought. But we started quite early in the pandemic when we saw a particular no-bid contract being handed to a problematic US spy tech company called Palantir to manage a vast new, unprecedented, really, store of data that was supposed to be for the COVID emergency called the COVID-19 data store. That, for the first time, I think, in NHS history, was pooling a lot of different, very quite sensitive health data sources into a centralized government database, supposedly to give the government decision makers a, quote, single source of truth about the response to the pandemic. Now, the government, the kind of officials at NHS England who were pursuing this system said, this is an emergency system. We understand that it will need to be unwound at the end of the pandemic. And we also know that it is going to be important to secure patient trust as we go on. That's what they said at the beginning. But what they then did was actually pretty politically different from that. So the first award went to Palantir. All regular procurement was suspended during the pandemic. The first award went to Palantir, the US biotech company, for £1. The price then went up and then went up again. So it was £1, £1 million, £23 million, which was the last deal that they bid for. And now that we are kind of winding out of the most emergency phase of the pandemic response, or at least one where the officials admit the emergency, the government is looking to procure a vast new permanent system. Not an emergency system, a permanent system called the Federated Data Platform, which it envisages will be, if anything, bigger and better. So it's a platform, if you will, for managing GP data, potentially hospital data, and social care data as well. The idea is that it all kind of comes in and is readable by a centralized government system. And as best as we can understand, the front runner to win the contract, where the people in government driving this would like to give it over, is to this really problematic spy tech company called Palantir. If you ask me what it's for, I sometimes think that the people procuring it don't entirely know what it's for and aren't totally clear about the use cases. But they say things like, oh, well, this is going to kind of cut your waiting list. I mean, certainly the platform can't do dialysis, so I'm not entirely clear exactly whether it's going to solve the structural problems with the NHS. But the stated aim is essentially to pool data and, again, make it available to planners, commissioners, decision makers, and as far as we can tell, potentially researchers for a bunch of different use cases. There was also a bit of a sleight of hand going on about what is actually being done to the data and how anonymous the data is when it goes into the system. So to be honest, we don't know yet. There's a lot that we don't know. And this is why we're writing legal letters to the government to seek to find out what technical procedures are being used to protect people's privacy. But the stated position so far of the government appears to be that it has gone through enough anonymization or pseudonymization processes, and that's not the same, that they don't have to honor people's opt-outs. So there are about 3.3 million people in this country that have now opted out because of concerns about trust and who accesses their record of health data sharing. And as best as we can understand, the stated position is that those may not be honored. So those are the kinds of questions that we're putting to the government about the system. Anyway, I could talk about the kind of long run of litigation that we went into, but I think it's actually more important just to go to the now at the moment.
That's great. Thank you, Corey. Thank you so much for that background. And you touched on this just a moment ago there. So just yesterday, Doctors Association UK, of which David is here representing, and the National Pensioners Convention and Just Treatment with Foxglove's support sent a legal letter asking lots of questions about the Federated Data Platform. David, I wonder if I could invite you in to talk a bit about, why you sent that letter, what your concerns as a GP are about this new system and the way that it's being rolled out, or potentially being rolled out. What are the concerns that you have?
Well, I'm not a GP, I'm a consultant neurologist, but actually it's good to have a secondary care doctor as well as Marcus, who is a GP. Because actually, when the genie's out of the bottle, you can't put it back in. And for all the reasons that Corey has illustrated, these are actually really fundamental questions about who has access to what is actually our data. It's not, and they're quite reasonable questions that are actually in terms of the governance of the data, and the issues in terms of informed consent. And I find it quite troubling, actually, that you haven't even had a reply, which is why I said, actually, this is rude, So, but it, and, even as a patient, I think about this, I've recently had surgery myself and things like that. And, so both as a patient and doctor, I think these are really basic questions of trust. And trust is very important in doctor-patient relationship, and it's also very important in terms of use of data. So I think the questions that are being asked are entirely reasonable, and any reasonable person who understands GDPR and IT would expect sensible answers to those questions.
Absolutely, and not to put her on the spot, but I understand that Jan from the National Pensioners Convention is actually here in the audience too. And Tom, if you wouldn't mind unmuting Jan, and Jan, if you wouldn't mind turning your video on, it would be really interesting to hear the same answer from you at the National Pensioners Convention, and to hear more about what your concerns are and what the concerns of your members are. And also, David, I'm sorry, I know you're not a GP. That was my mistake. But Jan, it would be lovely to hear that answer from you too.
That's okay. I mean, I came into the event because I was really wanting to hear what other people thought, because obviously we've been working with you for some time. But I think from the point of view of older people, for us, it's more about the use of that data. We've got no problem, and we would really love them to use data to improve services and actually construct new services. But a lot of older people have got very complex health issues, and we're a little bit frightened that the data may be used for some kind of postcode lottery around if some health conditions are more expensive than others to treat. So it's really around safety of data, and older people are very wise to the fact that not always what the government says is always what is true, and they would really, really like to be consulted, and before being consulted, to have a real understanding in layman's language exactly what the government are doing. And I think from us, the NHS Digital issue, which came before this, was massive for them, and this is still massive. So we want to see exactly what they want to do with our information. Sensitive information brings a lot of money to those who have no scruples and how they want to profit from themselves. So we are there not just to protect older people today, but the older people that follow us, and also those that are not digitally included, because it's not just older people that aren't digitally included. There's lots of young families who can't afford devices and broadband. So we want a really open, honest kind of connection, and to make sure that we understand fully before we walk into it. But the main thing is the data belongs to us. It doesn't belong to anybody else, and nobody should take it without our permission.
Yeah. Thank you, Jan. Thanks. It's really good to see you and hear from you. And I personally am very glad that you all have sent such a letter and look forward to hearing some of the responses to some of those questions. And I want to come back to some of the points that you raised there about consultation and consent and that sort of thing. But I wonder, before we get into that, Marcus, I wonder if you could talk a little bit about, back to basics here at the moment, how is, hopefully this is possible to answer this in some sort of simple way, but how our health data is currently managed, and what will change in terms of the way that our data is managed if this new federated data platform happens.
Yeah, well, the fundamental key factor you need to know about how your health data is currently managed is that there's a clinician in charge of it. And those clinicians, those doctors, GPs, for example, have taken the Declaration of Geneva, which is derived from the Hippocratic Oath, and it is about I will not share my patient's secrets. So when you tell something to your GP, when patients talk to me, they are telling me things that they would not dream of telling to just anybody. And I then record that in the notes because it's important that there's a record of what's been discussed. And at that stage, everybody is happy and secure and safe, feeling, well, my GP knows my secrets, but that's not going to go any further. What we don't like is the thought that without the consultation of the patients and without the consultation of the doctors, the government wishes to extract data and take it into essentially their own possession. Now, that we don't really have enough information about what is proposed to be able to adequately assess what risk we're running there. But what we can say is it's very different from I've told my doctor a secret and he's keeping that secret for me, which is the sacred trust that doctors have had between them and their patients for thousands of years.
Thank you. And a lot of so I think everybody in their answers so far has touched upon the kind of trust issue and the importance of a relationship of trust between doctor and patient, and is the whole, and the whole basis of the NHS. I think or the NHS is based on trust. I think it would be interesting, David, just to hear a bit more about what you think these proposals, the risk that these proposals pose to that patient and doctor trust relationship.
Well, some of that, it's actually just thinking about the governance mechanisms, and by that, the critics of us would be say that we're just a bunch of tinfoil conspiracy theorists, when actually I am very much involved in research. I'm involved in a number of clinical trials. As a patient, I'm actually involved in research. But actually, as both, as a researcher, I go through a governance mechanism, an ethics mechanism. I have to have information governance sorted. I can't just, flog the data to some of the private company without actually knowing how that data is going to be used. And there don't appear to be governance mechanisms. Further than that, I actually work in inner city Birmingham, in one of the most deprived parts of Birmingham. And as soon as I saw Palantir's history, I just thought many of the black and ethnic minority patients would run a mile if they saw the way the data and there's been no conversation from NHS Digital that I've seen, unless Foxglove can say otherwise, about what the governance mechanisms are. Is that correct, Corey?
There's very little detail available, I would say. Yeah, we wrote a letter some months ago that has received no response about the kind of consent processes and the governance processes, and that has received no reply. So we've written a second letter. That's right. And I would just to echo that point, just to completely agree with you about the risk to patient trust not being sufficiently considered, I think, by the people thinking of making this as an award to Palantir. I like you, I live in an area of London that is very heavily non-white, very heavily deprived. I live in Brixton, and every time I walk by my tube station, I would say maybe once a week, there is a group of people who stand outside the tube with a kind of a boom box and a sign and a rap blaring out from the boom box that says, "Brothers, sisters, don't take the vaccine, don't take the vaccine. And the story that is being told there is a story of a breakdown of trust. It's about the idea that the government actually doesn't have your community's best interests in heart. And so why would you participate in a system that wasn't actually built to protect you? And to be clear, I have had all my jabs, and it's really good for everybody to take them. But I think that lack of trust is reflected in a very low level in my community in Lambeth of vaccine uptake. And I think the provision of services, core sensitive health data management services, to companies whose almost entire history has been spent supporting the intelligence services, special forces, predictive policing, border enforcement, for them to pivot straight from those contracts into the management of sensitive health data, I think is a huge and obvious risk to patient trust that hasn't been considered enough by the people in government who want to give them this £360 million contract.
Can I ask you a little bit? I'm keen for us just to talk a little bit more about Palantir here for a moment, because they've, as you mentioned at the beginning, Corey, they've been they've been involved or trying to get involved in NHS health data right since the beginning of the pandemic. And I'm interested, Corey, if you can just talk a bit more. I mean, some of the people on this call know Palantir all too well, but I wonder if you can just talk a bit about who Palantir are as a company and what your current concerns are about their role in the NHS as it relates particularly to this topic of patient trust.
Yes. So as I said, I mean, they aren't particularly a healthcare IT company at all. Their origins are in the security services and in the military. One of their earliest funders was In-Q-Tel, the CIA's venture capital arm. Who knew the CIA has a venture capital arm? Anyway, but the purpose, they like to say, well, we're not Google, we're not Facebook, we're not here to sell your data. But that seems to us to be entirely beside the point. What they exist to do is to help state bodies, government customers, crunch, aggregate, and do what the government body wants to do with its data. So if that is targeting people for drone attacks in various places, they've been involved in that. Indeed, on an earnings call just last year, I heard the CEO, Alex Karps, or maybe it was the COO, I can't remember. Anyway, some senior Palantir person saying they still want Palantir inside of every missile and every drone. So it's very much a company that wants to manage all government data for all time. The Lord giveth and the Lord taketh away, be involved in preserving some people's healthcare and taking away other people's, without thinking about whether actually politically that hangs together at all. There are also some other concerns actually with Palantir that aren't just about their history with the security services and predictive policing and border enforcement, which have to do with essentially value for money. So there have been, and this is totally outside the healthcare context, there have been a number of investigative reports into Palantir services as used by those other government customers. So let's say California police departments, for one example, where the California police departments found that once they had gotten locked in to the Palantir system, that the system got more complicated, that it didn't talk to other systems, and the price never went down, by the way. The price only ever went up, and it got more complicated and more difficult for people to use, such that they wanted then to back out of the system. They felt that it was no longer serving their purposes and it wasn't value for money anymore, but they found it very difficult to transition out of. And I'd be really interested to hear more from a specialist like Marcus in IT about this issue. But vendor lock-in, as they say, is a real problem, which is to say, they've built this bespoke service. It requires very specific personnel to manage it. I mean, they have actually specifically hired very senior NHS personnel away to go and work for Palantir now, I think, frankly, because they think it will help them win this contract. But we have a serious concern, wholly apart from the trust issues, that once this company is locked in to the core of NHS IT infrastructure, that it's going to be extremely difficult to get them back out again.
Marcus, did you want to come in on that, particularly around the point that Corey made about vendor lock-in?
Well, on vendor lock-in and also on the price. So vendor lock-in, there is no particular reason why an organisation with the resources the size of NHS England could not actually build a platform like this for themselves, which we would own as taxpayers. The intellectual property would be NHS intellectual property. And then we wouldn't be on that vendor lock-in merry-go-round where we can never get away from Palantir. So I have grave concerns about going with any platform, whoever's produced it, on the basis that when the entire NHS is functioning from direct care all the way up to population health, taking in planning and research, when all those functions are completely dependent on one platform, you can never leave the platform. So I think it's a very dangerous road to take. And the NHS has had numerous opportunities to learn about vendor lock-in over its past history with IT. We can see how GP systems have essentially landed us with a duopoly of vendor lock-in. On the subject of the price, that's a very interesting thing. I was actually at an event some weeks ago where I was able to talk to, in confidence, an organisation which believes it may be putting in a bid against Palantir in the procurement. And one of the things that they said was they had no idea where the number of £350 million has come from. And so trying to think, well, why have we started? The thing that we know most about the federated data platform is that it's going to cost £350 million, which is an utterly farcical and almost comical situation to start with. We don't know what it does. We don't know how much it does. We don't know how long this contract will last. We don't know what it will do, won't do, what the protections are. We know nothing except someone's decided that that thing will cost £350 million, which is comedy gold.
Tori, I can see you laughing. Is there anything you want to come in on that?
No, I mean, it's a great point. That's what I meant when I said I sometimes think the people buying their very shiny IT toy don't quite know what they're spending the money on. I mean, I think the other thing I would say, and maybe David would have something to say about this as well, against a backdrop of trust and a struggling NHS is, it's all very well. We all want the NHS, it can't be said enough, to kind of use data in a trustworthy way better to help the NHS. We all see the NHS struggling. But one of the things that I worry about is that, particularly with some ministers and people in government, stuff like this, a kind of shiny data platform, you sprinkle the word AI in there somewhere, sucks up all of the policy oxygen from incredibly urgent issues that the NHS is facing. For example, the workforce crisis. I mean, very earlier, the health secretary was absolutely slammed by every professional organization in and around the NHS for a total absence of a workforce plan, right? I mean, it was when the health secretary was Therese Coffey, but she basically said, oh, well, let's wave our hands and say no one should wait more than 2 weeks to see a doctor. And, every professional organization within the NHS said, thank you very much. Thanks for that. Thanks for declaring that people shouldn't have to wait. Now, what are you going to do to make that possible? And the idea, I think, that a whiz-bang dashboard is the most important thing to make that happen just strikes me as being kind of coming at it from the wrong end of the stick. But I don't know. I mean, as I say, I'm not a healthcare practitioner. I'm interested in what both of you think about that. Does it take, I mean, I'm sure there's some better version of this that could help, but do you worry that it takes oxygen away from other more important and urgent issues?
Yes, it does. I mean, Steve Barclay was the one that suggested the ambulance crisis could be sorted out by an NHS hackathon. I mean, couldn't make it up.
No, I completely agree. It does suck all the oxygen out of the environment in terms of, what we already know there is a crisis. Having more data about the crisis doesn't necessarily equip us any better to address the crisis. And what we will end up with is the most accurately monitored and most detailed account that you could possibly have of a total collapse of the NHS. We'll have all the data about how it collapsed. However, we didn't expend that time and effort preventing the collapse.
Just going back to the issue of trust, and it really doesn't matter what I, as a white 57-year-old doctor, think, but it really does matter what my patients think. And I tweeted this earlier. Any medical student who's done anything about ethics knows about the Tuskegee study, which was in the 1930s, where basically black population in Tuskegee in Georgia were deliberately infected with syphilis to look at the natural history of that. And that created huge mistrust. And my worry with this is, as I said earlier, when the genie's out of the bottle, we can't put it back in for the reasons of cost and everything else that Marcus and others have stated. So these are fundamental questions of consent and trust that we must get answers to. It is as basic as that.
Thank you so much, David. Just to flag, I'm not totally sure. We're having a few issues hearing you. Hopefully, I can understand what you were saying, and hopefully the rest of the audience can. But please do raise it in the chat if you're having difficulty hearing, and we'll try and work that out technically. Corey, unless you have any other burning questions, or Marcus, there's anything you wanted to add on that, I'm inclined to come to some of the excellent questions that we've been getting in through the chat. First up, we have a question from Darina Angelova. Darina, did you want to ask the question yourself and turn your camera and video on? Or would you like me to ask it for you? It was a question which perhaps I can ask it for you and you jump in if you're here and wanted to comment or expand on it. And I think given the kind of response or the conversation so far has been, we know very little apart from the cost, perhaps this will be too tricky to answer. But many of the people on this call will be very familiar with the NHS Data Grab and the work that many of the groups that are continuing the fight did around the GP Data Grab. And during the GP Data Grab, patients were allowed to opt out of that. And I think, Corey, correct me if I've got the numbers wrong, but I think over 3 million people, is it 3 million or 1 million, Corey?
The current total is about 3.3, but there was a spike of opt-outs when there was a kerfuffle over this data grab you're talking about in about a month, where there were a little over 1 million fresh opt-outs because of the lack of trust in the system that you're describing. Yeah, but that took the total to about 3.3 million now. Yeah.
Thank you. You're always better on stats than me. And Doreena's question is: with this new system, can individuals opt out from the federated data platform? If not, how will people be informed about what's being done to their data and how it's being processed? And I think you're all going to say the answer is we don't know all of the answers yet. If that's true, I would be very interested in your view on how that should be done in a way that builds patient trust. Who should I go to first? Maybe Corey. You look like you're about to say something.
Yeah, I do have something to say about this, because I think there's a pilot going on now that we are concerned is setting precedent for how they're hoping to run the federated data platform. Although, again, there's so much that we don't know. So before even announcing this tender, before putting it out to bids, the federated data platform, they've announced a pilot. And by announced, I don't really mean announced. I mean that the lovely Sam and Phil of Med Confidential found it buried in the minutes of NHS Digital, which is the same as it being at the bottom of the basement cupboard behind a sign that says "Beware of the Leopard." But anyway, what the minutes say essentially is that they're running a pilot called Faster Data Flows, which isn't the whole shebang. It's not your, it's not your social care data. As far as we can tell, it's not your GP data. It's some hospital data, including some patiently identifiable data that is going into the centralized system. And as we understand it, all of the trusts are being directed to put the information into the system and being directed to use Palantir for this system. Now, in the minutes, the analysis of this so-called pilot does something quite funny. Because this question around opt-outs comes up, and they basically seem to suggest that opt-outs don't have to be honored for this process because the data has been, and then there's a bit of a waffle here, it's unclear which they mean, pseudonymized or anonymized. Now, I don't want to sit here and do a 15-minute disquisition on the GDPR to you, but these two things are different. They're factually different. They're legally different. Anonymous means that's it. We can't know it's you. It's statistical data. It's aggregate data. There is no chance of putting the jigsaw back together and being like, there's Martha, there's Marcus, there's Jan, whomever, right? Pseudonymized is different, because if you substitute little bits and pieces of data for you, like your NHS number or what have you, then with a reasonable level of technical competence, it is possible to reverse that process. What that means is that in law, you still have the right to a say about it. Consent is still necessary for pseudonymized data. But in this pilot, there's a suggestion that they don't have to go through that. So that, in fact, this is the legal letter that we have actually just sent on behalf of DA UK, National Pensioners Convention Just Treatment, basically saying, dear sir, it appears to us that you appear to be conflating pseudonymous and anonymous data for your pilot. Is that what you're intending to do for the FDP? And also, what gives? How have you not learned the lesson from last year's NHS data grab that the questioner rightly raises, which is, people have expressed a view. I mean, some 3.3 million have expressed a view that they now don't want to share data for purposes beyond their direct care. So what are you doing skipping this step? I mean, the last thing I would say, and then I'll let somebody else actually get a word in edgewise, is it feels to us like the government has learned the wrong lessons from last year's mess. GPDPR in many ways seemed to have much more consultation and thought that went into it in advance than this system. And still they kind of basically lost the engine, lost the energy, lost the ability to get done what they wanted to get done because they didn't explain what they were doing. They didn't explain what private access was going to happen. People didn't trust the system, and so the system essentially fell over. They then said that they were not going to do that again. They said that they were going to take time, build trust, go more carefully next time. But it feels to us that having declared that with the FDP, instead of saying, okay, let's bring people with us, let's be very specific about what we want to use data for and how that's going to work and how the governance will work, they've just said, all right, let's just kind of assert that it's been anonymized and kind of skip this step and hope that we don't have to honor those 3.3 million opt-outs, which is exactly the backwards lesson of the one that they should have learned.
Yeah, thank you.
Yeah, agreed.
Yep.
Go on, David.
That's just me agreeing. Well, I 100% agree. I mean, they learned precisely the wrong lesson. I mean, just all we wanted was a consultation and so in a sense, we're asking the same questions we asked over a year ago.
Thank you. Marcus, is there anything you wanted to add?
I would just add that I was the chair of the health informatics group of the Royal College of GPs for 2 years. And in that time, we did a huge amount of consultation with NHS Digital and NHS England about the GP data for planning and research platform, which is colloquially known as the GP data grab. But actually, there was an immense amount of work done to learn the lessons of care data, which was the 2013 ill-fated, even worse attempt to grab a whole load of data with no consultation and no opt-out. And we worked carefully with the team at GPDPR to try and bring them round to that sort of gradual process of earning trust. And we were making progress. And it just seems it's a great shame that that program has had its funding cut to by I can literally use the word decimated because it has been reduced by 9/10, and one has been left. One tenth of their funding has been left, which essentially cripples and kills the project. But none of the lessons of that have been brought over into the FDP, which is a completely different team, and it's within NHS England rather than NHS Digital. And I would add one further point, which is that in that 2 years where I was working closely on a number of issues with both NHS England and NHS Digital, is that their understanding within the organisation of information governance law and data protection law was actually quite astoundingly poor. And this was demonstrated on several occasions across numerous different programs of work. And, that's why we need external bodies to be able to properly oversee what is done, because we don't, as a profession, have the trust that they actually know the difference between their groupthink version of anonymization and their groupthink version of pseudonymization, and the kind of mashup that they seem to have created to exempt themselves from rules that they find inconvenient.
Thank you. Thanks so much to all of you. I'm going to come to another question from the audience, if that's okay. We have a question from Steve Bush about positive alternatives. Steve, do you want to turn your microphone on and ask your question? I can ask it for you if not, Steve. Shall I? I'm going to do it. Okay, so Steve's question is, we've talked a lot about the negatives of using data, especially when contentious private companies are concerned. What are the panel's thoughts on possible alternatives? I guess, Marcus, you touched a bit on ways that this could be set up differently earlier, but also I suppose, Palantir isn't the only provider out there. What are your thoughts on either alternative ways of setting this up or alternative companies that could be better options for our NHS than Palantir? And perhaps, Marcus, we'll start with you if that's okay.
Okay, yeah, so I think before I even thought about a company, I'd be thinking about trust. So I would want to engage with the profession and with patients to explain what the need is and what the proposed platform will do. And I would also explain how it will be overseen. So we have doctors and in this country, doctors have a regulatory body because every group of professionals has to have some kind of regulation around it, and that includes NHS England. So I would be proposing what is going to be the regulation, what is going to be the fail-safes around this platform before I even thought about software companies. My next step would then be to specify exactly what is required and see what companies were available that had the capability to produce that. But the most important thing I'd do at that stage is I would specify that when a company builds something for me as NHS England, I still own it. So they're a contractor that has been asked to build a platform for NHS England. That if it's like contracting a builder to build you an extension on your house, and somehow the builder ends up owning the extension and charging you rent. That would never happen in the real world. But somehow in the software world, we seem to walk into that as the NHS every single time. We pay someone to build us a bespoke platform, which that company then ends up owning and renting back to us. So a lot more business nous in the NHS in terms of its contracting and procurement, so that we end up owning the things that we've paid for. So another way to achieve that same aim is to insist on open source, which people who know me well will be surprised that I've lasted 49 minutes without mentioning. But open source is the only way for medicine. It is the only way to ensure that the tools we use in medicine are available to generations that are yet to come. In the same way as medical knowledge is passed down through the generations. We cannot have parts of the medical tooling, the essential software that's required to perform medicine, drifting into private hands such that they will not be able to be passed on like the corpus of medical knowledge can be passed on.
Thank you. David, we'll come to you with the same question.
Well, everything that Marcus said. The other thing I would add is a hospital doctor. I've got a particular interest in neurogenetics and genetics of complex disease. So actually, we've done a lot of this stuff in terms of the complexities of genetic testing, for example, and understanding how data gets used and having proper, ethics committees to review how studies get done, and also, patient information sheets. And it's quite a very complex process, but it's, basically what Marcus said is how that data then gets used. But this is our data, and it's how that gets used by the NHS, which is key.
Thank you. Corey, is there anything you wanted to add on that?
I think what I would just say is we're hoping to publish a little bit of a blog on this in a little bit. We've had a lovely researcher help us go out to look for comparative examples of kind of countries and places that have started to do it differently, including where systems are have a little bit more local control. So there's some interesting examples from places like Estonia and Canada. So I would just say, watch this space, watch the Foxglove website, because we hope to. Sometimes there's something a bit depressing about this debate, which is that it feels like the two sides kind of talk across one another and never kind of come to a central perspective, which is, well, all right, what are we going to do? Like, how do we actually try and solve this problem? I would say on their part, they need to stop using data saves lives, because that's a slogan rather than a plan. But equally, I think we are very open to a conversation about how that is used better in a way that preserves patient trust and patient choice. And also, look, there are interesting homegrown examples. I think somebody may have, asked a question referring to Open Safely. Now, I'm not saying that Open Safely can do everything that the government would like to do with data. I frankly am not enough of an IT specialist to know. But at least just to explain to people what Open Safely is. So there was a team at Oxford, including a guy called Dr. Ben Goldacre, who developed a platform that was supposed to be a more trustworthy, more open, more privacy preserving way of carrying out certain kinds of research during COVID. This is called Open Safely. And there are questions about whether such a system might be more generally useful to the NHS than these private walled gardens where you achieve vendor lock-in and the price goes up. Marcus, I mean, I don't know whether you have any reactions to potential, kind of greater use of something like Open Safely for some of these use cases. But it's only one example, but just to say, again, oranges are not the only fruit.
I would agree that Open Safely has demonstrated not only the technical capability to produce a working platform in a very short period of time that did exactly what we needed it to do whilst being privacy preserving, but also I would say it's not just what they delivered, but it's the ethos and the approach which you could use in every part. So their initial approach to the problem was, how do we make this trustworthy? How do we make it open? How do we make it transparent? How do we prevent gaming and abuse of this system? And they've used openness as a part of that. So they've queries in Open Safely are published openly on GitHub, so that query, you couldn't have some kind of nefarious query being made, because it would be public to see that it had been made. And I think so Open Safely absolutely is a paragon of an example as to how you might approach this going forward. The other thing that Open Safely patently is it's not the government. Because I think one area that we've not discussed in this debate is that NHS England, even though it says NHS, is a wholly owned, essentially a kind of subsidiary of the Department of Health and Social Care, which is entirely part of the government. And I think that whatever your views about the current government, there is no government that can be implicitly and permanently trusted, because even if you have a trustworthy government now, the next government could be untrustworthy. So you have to design your systems as though the government is not to be trusted. And I think there's a grave concern I have about increasingly identifiable and very disclosive parts of your medical record ending up in the hands of essentially the government, because we have no way to safeguard against nefarious government action. If the Home Office rings up the Department of Health and Social Care and says, I would like a list of, and then name your minority group, it could be, I would like a list of people who we think are illegal immigrants. I would like a list of traveller communities. I would like a list of people whose medical records imply that they are non-binary or have some other kind of identification which could cause them harm were it more widely known. What's the safeguard? And I asked Ming Tang this last week. What is the safeguard to that would not and could not ever happen? And I didn't get an answer.
Could you just explain who Ming Tang is for those who don't know, hopefully?
Ming Tang is the Chief Data Officer, I think, at NHS Digital, which is merging with NHS England. And actually, I'm not in any way criticising Ming Tang herself. She's the figurehead of a project which we would like to see more transparency about, and we would like to work with her to get that. So this is not an ad hominem attack, but this is just more about we're all in the medical profession. We all understand that data can provide great benefits, but what we can't do is jump to the answer with the data platform without putting in place the governance first. Not the governance after, but the governance first. And if they start to come to us with those kind of offers, offering to let us protect our own patients' data as it moves into data platforms, then they will have a different response from the profession and from patients.
Thank you. I'm conscious of time, but I'm hoping that people won't mind if we run slightly over, given we're a few minutes late starting. We have so many questions coming in through the chat, and we certainly won't have time to answer all of them. But what I think we could try and do, Corey, is create some sort of blog or Q&A questions that people had here. But one thing that we've just not covered actually here, I think, and that has come up a couple of times, Gronya, you had I hope I'm saying your name correctly, Gronya Tobin. Do you want to ask your question? You had a question about the kind of geographical scope of this. You all want me to ask your questions for you. That's what I'm sensing. I'm happy to. Shall I do it? Yeah, I will. Okay. So Gronya asked, and somebody else also asked about the geographical scope. Does this affect Northern Ireland, where there is where the health service is in an even deeper crisis and waiting lists are even longer? And then somebody else asked the same question for Scotland. Corey, do you want to?
Marcus will correct me, but my understanding is that this is an England-only system, in short. So I think that you in Scotland and you in Northern Ireland, I don't doubt, have other issues, but I think this is not the issue that you have to worry about.
Giving you a thumbs up, so I think you're right. You're safe there. Okay, so the kind of one of the last things I think, and I think this should be one of the last questions, because I think that most of the people on this call are incredibly invested in this work to safeguard NHS health data and to ensure that it's, like I said earlier, used in a way that benefits us, the public and taxpayers of the UK, and it stays a public asset. You've talked a little bit, both David and Corey, about the case and the legal letter that we sent recently concerning the federated data platform, and then the additional questions that we've sent about faster data flows. Could you just, Corey, talk quickly, or not quickly, talk about what's coming up next, what happens in the case, and what the possible outcomes could be? And then also, it would be great if either you or David could talk about what members of the public can do to support this case and campaign as it moves forward.
Let me answer very briefly. So in this country with judicial review, you can't just pile into court and sue. You have to engage in a round of correspondence first. So that's what we're doing. So you have to write to the person that you think may be violating the law, in this case, NHS England, and say, "Dear sir, what are you doing? And we think that you may be violating the law for the following 8 reasons." They then have to write you back. Now, in our prior NHS cases around Palantir, around the GP data grab, what we have found is that the simple act of writing to them and putting public pressure on them has significantly moved their position. So it may well be, I mean, we certainly hope that this doesn't need to end up in court. But if it has to end up in court, of course, we are prepared to support NPC, DA UK, and the Just Treatment to do that. But this is basically, these letters are the first step in legal action. So it will depend very, very much on what NHS England then decide to do, how they respond, whether they respond to these concerns and these pressures. And that's actually where the public, I think, play an incredibly important role, because it would be all very well to say, oh, well, it was our legal action that knocked over the GP data grab of last year. But that would be an oversimplification, because yes, we did threaten legal action. Yes, we were on our way to court. Yes, I'm sure that legal threat played a role, but all of you play an incredibly important role as well. And the real uproar from the general public about the lack of public consultation and the lack of consent, I think, was really vital in getting them to look again at that system. And it will be absolutely vital in getting them to look at this system again. So at the moment on the Foxglove website, you can find, for example, a right to your MP action, which is about this system, the new system, the federated data platform. And we would encourage people, if they are concerned about this, if they want more information, to participate. It's a very simple form in which you can write your MP. And also you can follow along for case updates on the website as well. And as I say, it is far too soon to say whether we'll actually end up in litigation, but we are very much on that train now if the government doesn't reverse course.
Thank you. And also, just to add on that, if you are not already signed up and you're interested in hearing more about this case and campaign as it progresses, you can sign up to follow Doctors Association UK, Just Treatment, National Pensioners Convention, and Foxglove if you're serious fans and want to follow all four. You can find out more about this as it progresses. Marcus and David, is there anything that you wanted to add as kind of a final thought on this before we close? David, perhaps we can come to you first.
Well, I think I can't emphasize the importance of writing to your MP. It really is important. In fact, my worry, it's going to sound strange, is there's so many things happening in NHS at the moment. I'm actually worried that not enough people will write to their MP because they're worried, literally about the ambulance queues outside or not getting cancer treatment, and that's actually very understandable. But this, in the longer term, we have to think. I'm afraid we have to, walk and chew gum at the same time. And I think writing to MT is incredibly important, because actually we don't want to end up in court. We just want to get answers to these very fundamental questions.
Thank you. And indeed, actually, I think I haven't seen the most recent count today, but I think about 1,700 people have now written to their MPs through that tool on our website. So please do share it and encourage others to do the
Excellent.
same.
That's brilliant.
Marcus, did you want to come in with any final thoughts before we close?
I think I would just agree with David that taking some kind of action, writing to your MP is an important thing. In a way, that perfect storm that enshrouds the NHS at the moment makes it easier for them to say, look, the last thing we want to pick a fight on is a data platform when we have ambulance queues and real material things that affect lives, people dying unnecessarily of cancer because the treatments are taking too long. So actually, it's a point where MPs can say, look, we don't need to spend £350 million on this, especially when we know it could be procured for a lot less. Let's can that project, kick it down the road, and do things that actually matter in the real here and now for the NHS. So in a way, it can be seen as a positive that there is so much going on in the NHS that a data platform can be something that can be sacrificed from an MP's point of view.
Thank you. Corey, before we close, is there anything else you wanted to add?
No,
Otherwise,
I just want to say it is such an honor of Foxglove to work in partnership with everybody. We would never be doing this without the Doctors Association UK, Just Treatment, and the National Pensioners Convention. So shout out to all of you for participating, and shout out to our partners.
Definitely. And our supporters too, for all of the MP actions, donations that have made the legal case possible, and support. It's much appreciated. But lastly, just to say a huge thanks to David and Marcus for joining Corey and me tonight. It's been invaluable to have your perspectives, and we really appreciate your time. So thank you very much for joining us. And I'm sorry we didn't get through all of the questions. There were genuinely tens of questions. There are about 30, I think. So we will try and do some of the kind of questions that kept coming up in a blog or something like that. And we'll be sure to keep you updated on the case and campaign as it progresses. Thank you so much for joining us, and have a good rest of the evening.